The thyroid hormones are regulated via a significant interaction between the hypothalamus, the pituitary and the thyroid hormone. Thyroid hormone is a iodinated form of tyrosine, which is an amino acid, and in a way the thyroid gland acts like a iodine concentrator of the body. So the thyroid gland located in the neck takes up the iodine from the body in the form of the sodium iodine symporter, which transports iodine inside. This iodine is then organified and bound to tyrosine to produce two major hormones. The most important produced from the thyroid gland largely is T4 or tetraiodothyronine, and T3 to a certain extent is also produced. This is then packaged in the thyroglobulin, brought back into the cells, and from there these T4 and T3 go to the circulation. Once produced by the thyroid gland, the thyroxine hormone has to be transported to its target regions using specific binding globulin. One of the most important of them is the thyroxine binding globulin. Over 99.9% of thyroid hormone is bound to the thyroxine binding globulin, and only 0.1% is free. It's important to understand it's only the free fraction which is going to result in the effect of thyroid hormones, and when we are doing a thyroid function test, we are mostly concerned about the free fraction, not the total fraction. Conditions in which the thyroxine binding globulin levels may go up, like pregnancy or the use of estrogen, will give us a falsely high level of total T4, but the free T4 levels will be normal. Similarly, in situations where the thyroxine binding globulin TBG levels go down, like liver disease or protein deficiency, the total T4 will be low while the free T4 hormone will be normal, and therefore free T4 is a better test as compared to the total T4. T4 or tetraiodothyronine is basically a prohormone, and it has to be activated into the active form T3. Now most T3 that the body gets is actually from the peripheral conversion of T4. So T4 is taken by the thyroxine binding globulin to its action site where it's converted into T3. T3 is the active form which has to enter the cells with the help of a transporter, which is the MCT8 receptor. And this transporter will bring the thyroid hormone to the cells where it will bind to the receptor. The thyroid hormone receptor complex will go to the nucleus, resulting in activation of genes whose proteins will be expressed, resulting in function of thyroid. The hypothalamus in the brain produces a peptide thyrotropin releasing hormone TRH, which acts on the pituitary to produce thyroid stimulating hormone TSH, which in turn results in production of T4 by the thyroid. Individuals who have deficiency of thyroid will have increased level of thyrotropin releasing hormone, followed by a normalization of T4. However, if the T4 levels continue to drop, the thyroid is not working at all, the next stage will be a low level of T4 and finally a low level of T3, because body will try to compensate by increasing the conversion of T4 to T3. So in somebody who has a deficiency of thyroid, the first hormone to go up is TSH, followed by a fall in T4, followed by a fall in T3, suggesting that T3 has a limited role in assessment of hypothyroidism. Around 1 to 2% individuals may have a problem in the pituitary or the hypothalamus and not in the thyroid, and in these individuals the TSH levels will not go up. So anybody who has a low level of thyroid hormone, that is T4, with a normal level of TSH, we should consider the possibility that this could be a central or a neurogenic form of hypothyroidism, and we need to evaluate using MRI to look for the hypothalamus and pituitary and look at other hormones as well before we start treatment, because otherwise the individual may have significant adverse effect.